If you suffer from Restless Legs Syndrome, RLS, this video is for you. I will be discussing these guidelines, which are the most recent clinical practice guidelines published in 2025. So this is the article which was published in 2025 in the Journal of Clinical Sleep Medicine. The first thing that we have to discuss is, are you sure that you have RLS? Because that's the main thing. You need to make sure that you have the correct diagnosis. Otherwise, it's not going to work. Whatever you do is not going to work. So let me tell you what is the diagnosis, how you make this diagnosis. And actually, the diagnosis of RLS is very easy. It's something that you can do even over the phone. And this is based on these criteria published in 2014. And you need all of them. You see that we have 5 here. You need all of them, especially the first 4. Number 1, you need to have a urge to move. You need to have the necessity, the urge to move your legs. And many patients describe this type of sensation in different ways, but usually they might say that they need to have some type of a stretch. Sometimes they say my legs refuse to sit still, and sometimes there are patients that they just complain of pins and needles sensation, which make things more difficult because that might be also neuropathy, or many patients they have a combined process. So, number 2, the sensation need to occur at rest, or at least worsening. Is worse at rest. This is very important. Number 3, if you move your legs and you walk, you will feel better. The sensation get better, or even goes away. Number 4, symptoms are worse at night, or at least late during the day. We call that circadian rhythm. Very important. And you need to rule out, or at least try to rule out, other things that looks like RLS, but they are not RLS. The problem is that many patients, they have a combined process and make things more complex, right? So if you have all of these 5 features, then you can say that you have RLS. Otherwise, no, you have something else. Now, this is the difference between guidelines. So in 2012 and now 2025, last year, there is some difference. So for example, in 2012, dopamine agonists were considered the standard first-line therapy for RLS. Not anymore in 2025. Not anymore. Dopamine agonists are suggested against as a standard therapy in patients with RLS. And the problem with this is what we call augmentation. Augmentation is basically things get worse. So if the symptoms started at 10 p.m., now start at 7 p.m. If the symptoms are just located on your lower limbs, legs, now affecting your arms, that means augmentation. So basically, everything is getting worse. And this type of medication, dopamine agonists, cause that. And when I say dopamine agonist, I mean these 3 medications that are the typical. These are the 3 medications that we typically use for RLS. Not anymore. So I'm talking about pramipexole, ropinirole, and rotigotine patch, which is the Nupro. And you see the genetic name and the commercial, the brand name here. Okay. Now that we know how to make the diagnosis, which is very straightforward, very easy. Now we need to emphasize what can we do to relieve or avoid exacerbation of those symptoms. So there are many things that we can do. And one of the things that these guidelines say is that you need to avoid, especially caffeine. So caffeine is something that I drink. No, nobody can tell me I cannot drink coffee in the morning. So, but this is strong evidence that caffeine make RLS worse, especially if you take caffeine later during the day. So if you are going to drink coffee in the morning only, okay, otherwise things are not going to get better. Nicotine and alcohol also you should be avoid. You should avoid the nicotine and alcohol because are related with worsening of RLS as well. Now, this is very important because these are medication that you are taking that might exacerbate or actually cause RLS. And these are the most common. So many patients, especially in US, they are taking antidepressant. And what happened with these medications? They might exacerbate RLS, Restless Legs Syndrome. For example, sertraline, which is a very common medication that we use. Sertraline is Zoloft, paroxetine, escitalopram, that actually we use it a lot, which is Lexapro, and also the SNRIs like venlafaxine Effexor or Cymbalta. This is Cymbalta. You can see that with tricyclic antidepressant like nortriptyline and amitriptyline. I use all these medications. All these medications might exacerbate RLS. Now, if you ask me which antidepressant is less likely to cause RLS, is this one here, Wellbutrin, bupropion. This is less likely to make things worse in terms of RLS. Now, this is if you take any of these medications, and there are many, the list is huge. Let me go back here. This is a high-risk medication that might exacerbate or actually cause RLS. Like anything that block dopamine, dopamine agonists might cause it. You see the list. And this is medication that we use, these three medications we use for nausea, like Reglan, very common, and Compasine and Phenergan. This medication cause RLS or at least exacerbate RLS and are the most common secondary cause of RLS. And this medication also might cause akathisia. Akathisia, thing like restlessness, but akathisia is usually due to this type of medication and is like having RLS, but all over your body. It's even worse. And then akathisia, those patients, they don't have the circadian rhythm. Like the symptoms, it doesn't matter if it's during the morning, at night, during the day, they have this sensation that they need to move. Akathisia is a very, very difficult condition to treat. Now, very common and frequently overlooked is this type of medication, antihistaminic, high risk. For example, if you have a mild RLS and you take Benadryl at night, you will see what's going to happen. You will have significantly worsening of RLS with Benadryl. And even this medication that we use for anxiety, hydroxyzine, another name is Vistaril or Atarax, might also exacerbate. If you ask me which antihistaminic medication is less likely to cause this problem or exacerbate this problem, is this one, Allegra. Okay, Allegra is the preferred alternative. Now, then what? You have the diagnosis, you remove the potential offenders, you treat your sleep apnea, make sure that you treat the sleep apnea, and still have the problem. Then what to do? So these are the medication. Well, before going to medication, you need to correct, and this is we're going by steps, okay? There are at least 3 steps. The first step is to correct and making sure that the iron is okay. Iron levels is okay. So what type of labs do you check? Ferritin, ferritin, and transferring saturation. I almost always check only ferritin, but some people check both. But the idea is that if ferritin is less than 75, and this is the magic number, 75, or transferring is less than 20%, you use iron, either oral or IV. I typically, when the symptoms are very bad, I don't even, I just go to IV infusion. But if you want to try, which is obviously cheaper, if you want to try by mouth first, then this is what you need to take. This is the you see here, ferrous sulfate, 325 milligrams with vitamin C. And you might ask, why vitamin C? Because vitamin C improves the absorption. So each time that you take the 325 or of this supplement, you take vitamin C 100 milligrams. So some people start with once a day. I always start patient with twice daily, and then you repeat the test in 12 weeks, as I mentioned here. However, if you want to go to the IV route, or the ferritin is from 75 to 100, then you have to use a IV iron, and this is the medication. Okay, and how much? 1,000 milligrams. This is a strong recommendation. Strong recommendation, and you repeat in 12 weeks. And you can do this again if you have RLS symptoms. They have again RLS symptoms recur or remain clinically significant, and your ferritin is below 100 or the transferrin saturation is below 20%. Now let's talk about medication. So if you already did and you make sure that you don't have any iron issues, and you replace and you remove the medications or other medications that might exacerbate this problem, then you might need to consider medications. And there are 3 medications currently to use. 3 medications only, and that's it. Gabapentin is my first choice, and I prefer this one because we have more evidence with this one. The only thing is really expensive, very expensive, and most likely the insurance will ask you to try gabapentin, regular gabapentin first. So I typically don't waste my time prescribing this one. I go directly to gabapentin or Lyrica. This is Lyrica Pregabalin. So I typically start with 100, especially if you are over 65. You have to be careful because the side effect of any of these medications are, and I will put it here, the side effects are sedation. This is the most common one, but many patients complain of dizziness. And many of them, especially if you go very high, weight gain and leg swelling. This is basically dose-dependent side effects. But sedation is pretty common. This is the most common one. And many patients cannot tolerate this medication because it causes a lot of sedation. But because the thing is, you are going to take this medication at night, that's okay. That's okay. You will be sleeping. But most important is this that you see here. So if your symptoms start at 10 p.m., at what time do you have to take the medication? At 8, 2 hours before. Take it 2 hours before symptoms onset. Otherwise, it's not going to work. Okay? So this is very important. So if you're going to try this expensive medication, Horizont, you start always with 300. That's the lowest dose. This is a capsule. Okay? So there's no other choice. It's 300 or 600. You start with 300 and then in 1 or 2 weeks you go up to 600. The FDA put here 5 p.m., but it's okay 5 p.m. But remember, 2 hours before bedtime. 2 hours before, 2 hours before symptoms onset. 2 hours before symptoms onset. If you have renal issues, 300 is the way to go. Okay? All these medications are eliminated by the kidney, so you need to adjust the doses based on renal function. All of these alpha 2 delta ligands. That this is the family of this. This is how you call all this medication. With Lyrica or Pregabalin, always start low. Always start low. 25 milligrams, 50 milligrams, and especially you are over 65. Okay, the way that you metabolize medications are not the same. When you get older, kidneys are not going to work in the same way. So you have to be careful with the doses. Now, going to step 3. If you have refractory, so nothing is working, you optimize iron, you are taking gabapentin, Lyrica, and it's not working. This is the 2 option. And actually, I personally, I will use this first before any medication. I prefer non-pharmacological treatment before taking a pill. Okay? So if you have the money to get this type of therapy. This is a stimulation. Okay? And I will give you in the website, so you can check the website of this Nidra, which is a device that stimulates the peripheral nerve, the peroneal nerve, which is the nerve that comes here lateral to the knee, inferior, a little bit distal of the knee. So it's a stimulation, high frequency stimulation, and seems to be very effective, but expensive. But if you have the money, this is the way to start before taking a pill. Okay? They put it like a step 3, but I will probably put it like a step 2. Now, again, I would try to avoid medication, especially this type of medication, opioids. But in severe cases that nothing is working, you might need to use oxycodone, ER or methadone. Those patients respond very nicely, and a low dose, actually, low dose of these 2 medications. But I always try to avoid narcotics as much I can. And if I'm going to use narcotics, it's this type of patient with severe refractory RLS. And you have to monitor sedation, respiratory depression. This is the side effect, and especially this one, dependence. Okay, you have to be careful which patient to use this type of medication. And just to summarize, number 1, you need to avoid medication that worsen or trigger RLS, including alcohol, and limit the amount of caffeine. And if you are going to drink caffeine, in the morning only. Treat obstructive sleep apnea. Sleep apnea, you need to treat. If you don't treat that, things are not going to get better. Doesn't matter what you do. Optimize iron, especially if you have deficiency, but not necessarily. First line of treatment for me is this. Okay, before a pill, I would try the peripheral nerve stimulation, Nidra. And if you need a medication, I will start with Lyrica or Gabapentin, or this expensive medication, Horizon. Okay, this is the most effective one. And then Lyrica, and then the third one will be Gabapentin. If you ask me about which one is the best, but this one is the best apparently, but more expensive. And in refractory cases, so when nothing is working, you might need to use a low dose of opioids. And remember, these 3 medications that are very commonly used for RLS, not anymore. No longer the standard of care. And the reason for that is because of augmentation. So basically, make things worse at long term. If you like this video, don't forget to subscribe to my channel. See you soon.